a warm welcome to the today's session of the first National Non-Communicable Disease Conference, Bangladesh. The conference is hosted by Non-Communicable Disease Control Program, DGHS, and jointly organized by Bangladesh Non-Communicable Disease Forum, Clinical Research Platform Bangladesh, and Bangladesh Health Reporters Forum. Now it is my honor to request the chair, Dr. Mustafa Jaman Sir, Advisor, Research and Publication at World Health Organization, the co-chair, Dr. Shams Al-Arifin, Senior Director, NCDs-icddr, the respected national speakers, Dr. Arun P. Jose, Dr. Alia Nahid Ma'am, Scientist, Head Initiative for Non-Communicable Disease, Dr. Rubana Rakib Ma'am, Climate Change, Senior Scientist, ICDDRB, and Dr. Afrin Iqbal Apu, Research Investigator, ICDDRB, to come to the podium and take their chair. Thank you so much. Thank you so much. Our today's session has three modalities. First of all, there will be welcome chair by the respected co-chair. Then the scientific session will start, moderated by the co-chair, where 5 esteemed invited speakers will provide their presentation. And finally, the respected chair will moderate the question-answer session and deliver his closing remark. So without any delay, I am humbly request the co-chair, respected co-chair, to come and moderate the session. Thank you so much.
Good morning, assalamu alaikum. Let me take the floor before the microphone comes to the dais. Non-communicable disease epidemiology in Bangladeshi population deserves special attention. There is no doubt about it. And Bangladesh has started the journey of controlling non-communicable disease long before. However, there was hardly any partner in the prevention of non-communicable disease. Say, I'm referring to around 2000. But now, there are a lot of partners for NCD prevention and control, and also for management of the NCDs. And Bangladesh is fortunate that ICDDRB has taken its journey for prevention and control of non-communicable disease. And today we will have very learned speakers from ICDDRB and one from outside the country to address the issues of non-communicable disease. So we are looking forward to the presentation. And with this, I would like to hand over the mic to Dr. Shams Al-Arifin, please.
Gentlemen, thank you. So my name is Shams Al-Arifin. I am from ICDDRB. I head the maternal child division there. I've been there for many years. It's a pleasure to be here to co-chair this session with Dr. Zaman. And since we're running a bit behind time, let's jump right into the presentation. Our first presentation, we have an international speaker, Dr. Arun Jose. I just checking whether he's supposed to be online, right?
I am online. Hello.
Thank you. So let me quickly introduce you. So Dr. Arun Jose is Deputy Director for Center for Digital Health, PHFI, Public Health Foundation of India. He's a physician and public health specialist by training and currently leads the digital health and capacity building programs in India. Dr. Jose was awarded the Global Public Health Leadership Fellowship at Emory University in 2016 and is fellow of the International Society for Cardiovascular Disease Epidemiology and Prevention and the World Heart Federation's Emerging Leaders Program. So with that, Dr. Arun.
Thank you very much. Would I need to share my slide?
So Dr. Arun, are you sharing your, oh yeah, so thanks. So if you can go on presentation slideshow.
Yes, I'm hoping that everyone can see my slide. A very good morning to everyone over here, and very good morning to all the respected chairs and the dignitaries on dais. So I intend to take my very short time to describe the importance and the increasing role of digital health in cardiovascular disease prevention and management. And I am sure that the Bangladesh Ministry of Health, as well as all the affiliated institutions, have been looking more deeply into digital health ever since the COVID pandemic has started. These are my disclosures. So, as we all know, the recent COVID-19 surge put immense pressure on the public as well as the private health systems across the world. Tertiary care facilities were overwhelmed with the number of cases of COVID, and currently, at least in India, we are facing the third wave of the COVID pandemic, where the number of Omicron cases have jumped in very large numbers. But the patients who suffer are not just the patients who have COVID-19, but it's also those who suffer from chronic conditions like diabetes mellitus, hypertension, bronchial asthma, CVD, and they've been severely affected due to the interruption of these health services. Most of these patients require regular checkups, and it's been very difficult for them to avail of health services during this last 2 years. And particularly, vulnerable sections of society, such as the urban and rural poor, the children, the pregnant women, and elderly, are some of the worst affected because of the pandemic. Now, we all know, and I know that all of you would agree, that a large majority of these issues can be effectively mitigated through the use of optimal digital health solutions. So before I begin on what are the digital health interventions that are possible for cardiovascular disease, in general, what is digital health? And this is a question that has been asked. What really defines the scope of digital health? And there are over 70 published definitions for digital health. But basically, it is a field of knowledge and practice associated with the development and use of digital technologies to improve health. And if I want to say it more elaborately, it is a proper use of technology for improving the health and well-being of people at individual and population levels, as well as enhancing the care through intelligent processing of clinical and genetic data. So now we're at an age where there's so much of clinical and genetic data that is available, and all of this could be effectively put to use to prevent and manage cardiovascular disease. The scope of digital health is vast. There are so many different forms and shapes in which digital health is there around us, and I am confident that most of these are already being put to use for various applications in Bangladesh as we speak. But in short, Internet of Things, virtual care, remote monitoring, artificial intelligence, big data analytics, blockchain, smart wearables, various platforms, tools that enable data exchange and storage, and tools that enable remote data capture and the exchange of data would encompass most of these. And how do they improve health outcomes? By helping with the improving of continuum of care, improving medical diagnosis, helping with data-based treatment decisions, digital therapeutics, which is one of the newest entries into digital health, where the prescription itself consists of digital therapeutics as a drug, for example. Clinical trials, self-management of care, and person-centered care, creating more evidence-based knowledge, and improving the skills and competence of professionals to support healthcare using digital medium. All of these are mechanisms through which the health outcomes of the population can improve. When we look at digital health interventions for cardiovascular care, I tend to divide these into three main domains. One is the digital health interventions that are available for self-management. Then there are a series of digital health tools for clinical care. And the last one is for health system strengthening. So there are various innovations available in the market today for self-management. The three key things are text messaging, smartphone applications, and intelligent wearables. So most of these self-management digital health tools today are those that are being used to improve lifestyle changes as well as adherence to medication. And text messaging has been one of the earliest forms of digital health that has been used for cardiovascular disease management, almost from the early 90s. With the lack of need for internet for text messaging and the ability to send large number of bulk SMSs at once, these text messaging systems have proved to be very effective in improving lifestyle changes as well as improving adherence to medication. There are many and many smartphone applications that have come out today that help with the same, which help with lifestyle and behavioral change. There are also a lot of applications that help with medication adherence. Now, the only caveat or the only drawback over here is that some of these applications have not been very scientifically made, and so it is very important to be very choosy about these smartphone applications, because some of them have not been made using a scientific basis, but nevertheless, they do help in improving medication adherence as well as in improving the chances of a successful behavioral intervention. Intelligent wearables. So this is something that has taken everyone by storm. Everyone has a smartwatch. So intelligent wearables are basically commonly used appliances that are now used for improving health. And the most common example that is used are the fitness watches. So now there are a lot of fitness watches. Most of them have been used to improve physical activity by helping people keep a track of their footsteps and also the number of calories that they've burned. But there is very conflicting evidence as to how much or how successful these intelligent wearables are in improving the lifestyle change. When we look at innovations for clinical care, there are very, very exciting digital health tools that are now available to improve clinical care in NCDs and cardiovascular disease. So there are a plethora of point-of-care diagnostics that are now available that help in making these diagnostic tools more portable, available, and accessible to the people. Simple innovations have helped very common appliances to become a point-of-care diagnostic. For example, by simply plugging in a transducer to a smartphone, now we can use it as an ultrasound machine. We can connect a blood pressure apparatus to a smartphone application and thereby monitor blood pressure over the phone. So there are multiple innovations that have come in the area of point-of-care diagnostics that help with screening as well as diagnosis of various cardiovascular diseases. Electronic clinical decision support systems are on the rise, and there are many electronic clinical decision support systems that are available in the market. One is has been developed by the Public Health Foundation of India itself. It's called the Empower, and this basically embeds multiple case scenarios, and it uses machine learning and artificial intelligence to provide the physician with the best clinical decision support for a particular patient, thereby improving patient outcomes. There is no need to emphasize on the importance of telemedicine, especially in this time of the COVID pandemic, where most of the health systems across the country have become very inaccessible to patients, especially the non-communicable disease patients. And telemedicine plays a very, very important role in improving clinical care in cardiovascular disease. Electronic health records is another innovation that has been used over the years, but now it has become more interoperable. Most of the health facilities in India, and I think in Bangladesh, also have adopted electronic health record systems for their health facilities. And this has immense potential to improve clinical outcomes by embedding machine learning, artificial intelligence into this and improving clinical outcomes just by using electronic health records. Digital pharmacies are another innovation that has been increasing in numbers, especially in India, where we have multiple digital pharmacies that make drugs more accessible and affordable to the patients. Intelligent wearables have also been used not just for self-management, but also for improving clinical care. And I'm sure many of you would have heard about the Apple Heart study, where using a Apple Watch in the US, they were able to track down multiple episodes of atrial fibrillation among patients. And this is a very successful study and provides a lot of hope in the use of these intelligent wearables for detection, early screening of various clinical conditions. Smartphone-paired diagnostic innovations are other innovations that are available for improving clinical care, and which I also touched upon briefly a little while earlier. Now, many of these digital health tools can also help in strengthening the health systems of the country, and telemedicine, for example, has been used in India over the last 2 years to help decrease the burden or decrease the number of patients that require to visit a large health facility, which has largely become inaccessible due to the COVID pandemic. Most of these health facilities have had an overload of COVID patients, and most of these doctors, as well as the other health professionals that work in these tertiary care facilities, have not been able to provide care to the non-communicable disease patients, and telemedicine can play a very important role in improving access, decreasing the cost of care that is associated with cardiovascular disease care. Electronic health records also helps in health system strengthening, and it is a good source for creation of digital disease registries that are becoming more common now. And it also helps in electronic health surveillance of the population. It helps to understand what is the trend of non-communicable disease in the country. Big data analytics. So there's a lot of data available today, and this can be effectively used for creating algorithms that can help with improving health system management. Digital education is another area that has been often neglected, and many of these on-site and in-person training programs can be easily taken onto a digital platform, thereby improving the health system of the country. Machine learning and artificial intelligence is another area that needs to be tapped into at now. So how can digital health help? Firstly, it improves the affordability of healthcare. It improves accessibility to healthcare, especially to the marginalized population. And it also improves the quality of care that can be provided. It has the ability to provide very personalized care as compared to large community initiatives, and it is scalable because of the cost factor, and it is also a very climate-friendly way of proceeding with healthcare. However, digital health also comes with a lot of challenges and threats. Firstly, the cost. The cost has to be made affordable to patients. Quality control and regulatory frameworks have to be put in place so as to improve the privacy of patient data. Interoperability of different platforms and digital health tools is another part that has to be taken seriously.
Dr. Jose, may I request you to wrap up soon?
Digital health providers so as to enable the use of all of these on an interoperable platform. Data concerns are something that has been of very big concern in different parts of the country, where patient data has to be kept secure, and it has to be kept in mind that the patient owns their data.
Dr. Arun, we would request you to wrap up the presentation, please. Thank you so much.
Thank you. This is my last slide. Yes, and another important thing to consider is the digital health equity part, where it is important to ensure that everybody has access to digital health. And as I would end with this one slide with the WHO Digital Health Strategy that says that it is the essential enabling factor that will ensure 1 billion people benefit from universal health coverage, better protected from health emergencies, and 1 billion people will enjoy better health and well-being using digital health appropriately. With this, I will end. Thank you so much.
Thank you, Dr. Jose. I don't know whether you can hear me. That was excellent. And there is a session time at the very end for discussion on the session today, but we can take 1 or 2 questions for clarifications. If there is any from the audience here, please keep it short to the point if there is a question for clarification. And if Dr. Jose cannot hear us, then maybe Nabila can transmit the question. আমি একটু রিকোয়েস্ট করব, আমার সবাই মোটামুটি ভালোই মাস্ক পরেছে, একজন বাদে যারা পড়েননি প্লিজ মাস্কটা পরুন প্লিজ. Let's move on to the next presentation. Let's move on. I think we will have to continue this.
Can't hear.
So the next presenter is Dr. Alia Nahid, a scientist and head of the Initiative for NCD and icddr. She's also a health systems specialist with strong background in epi, behavior interventions, clinical trials, policy analysis, gender analysis, and economic evaluation. With more than 25 years experience in health research in NCDs, and she has recently completed two large-scale trials on hypertension controls in rural areas in terms of prevention of type 2 diabetes among women with gestational diabetes. And also she has generated the largest data set in South Asia for assessment of risk factors for MI among patients who had a first ever attack of myocardial infarction. Also tested an innovative mental health service model for addressing depression among women in Dhaka. She's also created a clinical research platform in collaboration with the British Medical Journal and BSMEU, which is a very good bridge between clinicians and public health researchers. So with that, I invite Dr. Alia Nahid to make her presentations.
Good morning, everybody, with respected chair and co-chair dignitaries, online colleagues who have connected with us, and guests. With chair's kind permission, I'd like to take off my mask while I'm talking. Thank you very much for giving me the privilege to speak before you about one of the trials that Dr. Shams just mentioned. It was a kind introduction. So right after hearing from Arun, who has taken us to a modern life, I'm going to take you back to our primitive life where there was no COVID and digital health was not in our vocabulary. So before I go over that, I just want to remind you that you have heard from this morning from various speakers that in Bangladesh, NCDs attribute to 70% of the premature deaths, that is 30 years to 70 years age group. And if you look at the graph on the left slide, so our target is, by 2025, is much lower, but the blue line shows that we are far from achieving our targets. And as you know from the WHO's report from Bangladesh Profile, that 67% deaths are attributable to the NCD, and to be honest, 30%, one-third.
Do you have slides?
I do.
Don't see it.
Oh, God. Hey. So can you put my, I thought I could open it, but can you put my slides on show, please? Whoever is supporting the technical assistance. Thank you. So there is thank you so much. So the left-hand slide shows a line of where Bangladesh is in terms of burden of premature deaths, but the dotted line shows where we need to reach. So we are far from our targets. And as I mentioned, 30% of the NCD attributable deaths are due to cardiovascular diseases. And if I look at the left-hand side, this is very recent data that about 50% of women and one-third of the men, they already have hypertension, and this is an increasing burden in this country. And hypertension actually attribute to the two major causes of death in Bangladesh, that is stroke and ischemic heart disease, that is more commonly known as myocardial infarction or heart attack. If you look at the right-hand side graph, it did not change from its top ranking. 10 years back, the situation was exactly the same. So what are we doing? What have we done? So we probably did not do much enough. So this is the reason of the trial that we have conducted, not only in Bangladesh, but simultaneously in countries in South Asia like Sri Lanka and Pakistan, where the NCD burden is very high, but health systems is not yet equipped to support NCD care. Our objective was to evaluate a multi-component intervention in a rural setting to reduce blood pressure in rural communities, to identify the incremental cost of scaling up the intervention, and if that would reduce the cardiovascular disability at just life years. And of course, any intervention must be affordable and implementable in the community from both perspective of the patients and the providers. And we looked at the barriers and facilitators of this multi-component intervention. So this study was conducted in 2 districts in Bangladesh, and from each district, more than 1,800 villages were mapped to identify their distances from the relevant health facility, that is the primary care sub-district hospital, popularly known as Upazila Health Complex Hospital Center. So from the sub-district or Upazila Health Complex, 5 centers in Tangail and 5 centers in Munshiganj districts were selected randomly based on the distance. I'm not going to into that, but it was a very robust process of selection of the clusters and the participants that was done by a different group. So these, the participants were included from each cluster. The number was 85 per clusters. So there are 850 participants. They went through a long journey of 2 years. They had a baseline assessment, and every 6 months they had a follow-up of through their blood pressure monitoring, laboratory assessment, and data capturing. And at the baseline, and after 1 year follow-up, there was also some qualitative assessment for looking at various and facilitators. And finally, after 2 years, there is an end line. So these multi-component strategies included 5 areas. The first one was the home health-based education by the community health workers who are known as health assistants in Bangladesh. So they were trained. A pictorial flip chart was designed through a formative research, including all the best practices to mobilize blood pressure control and lifestyle modification. So, and the health workers used that in the community in a family setting where not only the patient but the family members were also invited to join the session. The health assistants also monitored blood pressure using a digital Omron machine, and they used a checklist that you see on the right-hand side, which is a new thing, and they particularly documented all the information of the patient, and if anybody had a raised blood pressure, uncontrolled blood pressure, they were sent to the health facility to see a doctor. And in the health facilities, doctors were trained how to treat hypertension by following an algorithm-based treatment management protocol, which was very new at that time. And the health systems and facilities were upgraded by providing simple tools like blood pressure machine, digital one, height machine, weighing machine. But at the same time, there was a designated triage coordinator who was actually coordinating the entire activities, both at the community and in the facilities, so that everybody is on board and patients are not deprived of the care. And for the patients who were poor, they were given a health card marked with yellow so they could get subsidy for the travel need to see the doctor in the facility, or if they need to buy any medication. But beyond that intervention, there was a National Advisory Committee, including the NCD Control Program Line Director as the chair, who monitored the entire progress of the program for 2 years. And I am heavily indebted to them for their contribution. And I'm ready to see some of the committee members are here today with us. So what we try to look at the changes in systolic and diastolic blood pressure compared to baseline after 24 months of randomization, and also wanted to understand the incremental cost of reduction of 1 millimeter of mercury and incremental cost per disability at this life year averted. And of course, objective 3 was a barrier and facilitation assessment. So I'll not go into this in details, but briefly, more than 1,000 villages were selected, and all the patients, 40 years and older, were screened using Omron digital machine by very trained research staff, and 10 clusters were randomly selected. From there, 4,400 plus were screened, and we found more than 1,100 participants who were eligible. They were randomly allocated to multi-component intervention clusters and usual care clusters. Usual care clusters were those clusters where we did not have the intervention, but government already has some NCD, corner, and other functions. So after 2 years of journey, we could enroll around 450 participants in both arms, and they were all included in the intention treat analysis. Briefly at the baseline, the demographic characteristics suggest no difference between the two groups in terms of income, education, family structure, age, and sex. So in terms of intervention fidelity, we found that in 2 years' time, there were about 100 doctors deployed in the 5 intervention facilities, and most of them were trained how to treat hypertension following an algorithm-based case management protocol guideline. There were 11 health workers who were deployed in the 5 intervention communities. They were trained fully and periodically trained through refreshers training every 3 months. And the triage coordinators were all trained, and they also received, the health workers also received periodic incentive for the extra work. The good news is that out of the planned sessions, 90% they could complete for delivering sessions, more than 94%, and they actually documented all these findings. That is fabulous in the community. And when the patients were referred to the health facility, doctors, for the first time, documented all their findings and also kept a record in paper what was the track of the changes of medication prescription. And we completed more than 80% doctors finished that. That is really fascinating. And very interestingly, only 2 out of 447 intervention participants, they actually claimed for subsidy. So that means people generally got the supplies from the facilities like drugs. After 24 months, what we found that for intervention clusters, or we had in the baseline and end line difference was about 519 millimeter of mercury reduction of systolic blood pressure in intervention area, whereas it was 1.18 millimeter of mercury in the control area. The note of interest is that after the baseline up to 6 months, in both of the communities, we saw sharp reduction of blood pressure control, and that was due to the close monitoring of the patients and referral to health facility for ethical reason for whoever had a blood pressure raised. But after 6 months, what we saw, that reduction of blood pressure was much higher, or change was much higher in the community in the intervention group, and it sustained through the period of 2 years, and that was quite fascinating. The blue line, it demarcates that, but the changes that we found in the control usual care that remained also sustained, but much lower than the intervention group. We have observed similar changes in the diastolic blood pressure, and it was impressive that 4.76 millimeter of mercury diastolic blood pressure change after 24 months, which was 2.49 for usual care. So, and we saw the sustained control of diastolic blood pressure through the year of intervention. In the cost-effectiveness analysis, it was a quite comprehensive exercise, and we estimated everything can be counted for systems delivery of the operation, considering future scale-up. So this is the line list of everything like the administration, training, implementation cost, supervision cost, and medical visits to the facility by the patients.
So what we found, wrap up soon.
Okay. What we found that the overall delivery cost after calculation, we found that the nationwide rural program delivery cost will be around 103 million USD for Bangladesh. But when we look at the effectiveness, we found that the treatment cost per 40 years hypertensive individual would be $10 if we consider to replicate this service not only for 40 years, but not only hypertensive, but all 40 years rural older people, it will be $3.5. But if you include all ages, it will be $1, and if you include both rural and urban population, it will be just 60 cents. So the more we include people in the intervention, the lower the cost is coming down, so it becomes very cost effective. And of course, not only cost, we found that incremental cost per cardiovascular disease daily averted was $3,000 for one DALI avert. For averting one DALI, we need to spend for $2,000. So it is not at all very high for a country. So we have these key findings nice changes in systolic and diastolic blood pressure both. It was very low cost for scale up, and it gives lifetime incremental cost of scaling up would be just 12,000 Bangladeshi taka. This is quite affordable, and it gives a lot of DALI saved as well. And when you looked at the qualitative one, we found that it was highly acceptable by both the providers and patients, and they found the intervention to be very useful, particularly the doctors. They found the algorithm-based treatment to be very convenient for them to provide standardized care, and they have seen a lot of benefits in the patient, and it shows that in the intervention we got a good impact. But there were barriers, and the time was a big constraint because they were tasked with many other jobs, and this close monitoring of the patient was, of course, a quite heavy burden on both the doctors and the health workers. And there are not always the medicine supplies available. So those are the issues came up. But irrespective of all these challenges, both the patients and providers, they strongly suggested the intervention must be scaled up for everyone. But there was another good thing. The good thing was that when you found that the community health workers were trained, they were not limiting their services only to patients, but also other patients who were not in the study. And they were also training their own family members for lifestyle modification. Doctors are giving the same treatment to other patients. And drugs were supplied for 1 month throughout the country. These are all very good positive impact. So what we recommended that COBRA strategy is ready to scale up in Bangladesh, but that there needs to be some modality change. So it cannot limit only to primary facility, Upazila Health Complex, but must be drawn down to community clinic with a linked referral system that is quite functional. Drugs must be available for refilling for patients, and periodic training for hypertension management of the patient, and engaging health workers in monitoring at the home base. But it would require also compensation. And it all creates a lot of involvement, human, but which is not possible in COVID-19 situation. This is how, going back to Arun's recommendation, that we need to digitize this strategy, and the cost would be much lower than if we can functionally utilize our existing workforce, but building their capacity, enhancing their skills to use the digital platform to implement the COBRA PPS strategy. So it was a great journey for us to work with so many people in the community and the health systems, drivers, managers. I just can't name, and they were so supportive, and I convey my heartfelt gratitude to all of them. And of course to the funders who made it happen, and the beautiful team in ICDDRB who took all the pressure and pain to make this effort successful, and the patients. They have believed in us, and they have stayed in the intervention. They helped us to evaluate this wonderful multi-component intervention. Thank you very much for your patient hearing.
Thank you. So I think I'll request, thank you, Nahid. And I think we'll need to jump to the next presentation because we're really running out of behind time. So we will have let's keep the discussion time at the very end. And the next presentation is on climate change, environmental exposure, risk factors for developing cardiometabolic diseases. This is also a presentation from a colleague from ICDDRB, Dr. Ravana Rakib, who is a senior scientist and is also head of the Enteric Respiratory Infections Program at ICDDRB in the Infectious Disease Division. Our areas of specialization include immunopathogenic mechanisms and host responses to infections, mainly on enteric disease and tuberculosis. And she has spent some time understanding the impact of environmental toxicants on human health, as well as looking at, she has worked on in terms of from both a range of studies, including preclinical trials, clinical trials. She has evaluated the impact of alternative and adjunct therapeutics in the treatment of diarrheal and respiratory diseases, particularly shigellosis and tuberculosis, with international and national partners. And also looking at mitigating toxic effects of environmental pollutants and toxicants through community-based interventions. So with that, Dr. Rakib.
Thank you so much, Dr. Arifin. Respected Chair and Chairperson and dear audience. So I'm going to talk about, sorry, I'm going to talk about generally about climate change and environmental exposure and risk factors for developing cardiovascular diseases.
Can we have the slides on the screen, on the two screens on the two sides, and as well as in the Zoom?
I don't know whether the Zoom people are able to watch it or not. So they are, okay. So most, as you know, that general public knows that most of the early research has been limited to lifestyle and dietary behavior as risk factor for cardiovascular and metabolic diseases. And now the recent accumulating data suggest that chronic exposure to environmental toxicant is associated with a number of cardiometabolic diseases, and contribution of these exposures to development of CMD is an under-recognized research area. So we know that CMDs are
The presentation
mostly
is not going online, please. The presentation is not going online. Can you fix the problem?
CMDs mostly become evident in adulthood, and environmental exposures in early life leading to CMD development over the life course are of particular importance. An assessment of CMD risk in childhood and adolescence is thus an important thing to define early contributing factors that may track into the adult life. So in a MiniMed cohort, which is a cohort developed in ICDRB's rural area Matlab, we have shown that early life exposure to certain metals and metalloids like arsenic and cadmium can influence fat and carbohydrate metabolism in 9-year-old children, and that may be associated with the development of CMD in later life. So our broad objective for that, which this particular presentation is, to characterize risk profiles related to environmental factors such as toxic metals, air pollution, salinity, nutritional factors, and behaviors such as use of tobacco, mobile devices, physical activity, sleep, etc., on the progression of CMD in adolescence. So this is I don't have a indicator, or otherwise I could have shown. So anyway, this is a cohort that was started in 2001, 2003, and we had around more than 4,000 pregnant women in rural Matlab. And we followed them at birth, and the children when they were at 4, 5 years of age, at 9 years, and at 15 years of age. And there were around more than 2,200 children, but here I'm talking about a smaller cohort of around 600 children. These are, we call them immune cohort. So here we collected data on maternal food and micronutrient supplementation, because the mothers were supplemented with food intervention, and the main study outcome was birth size increase. And then we collected anthropometric data, socio-economic status, and then we looked at metal exposure and different kinds of immune responses. And we collected blood, urine, and water samples from the children in the household. And I'm going to talk mostly about 9-year-old children and 15-year-old children. At 15 years of age, we collected some extra information about the environment, like the salinity of household water, air pollution inside and outside the house, and metal exposure. And then we looked at the biomarkers of cardiometabolic diseases. So these are the children at 9 years of age. You can see that. And the same children when they grew up at 15 years of age, all big boys and girls, going to class 9 or 10. So this is just the demographic characteristics of the boys and girls. They were around 50-50 boys and girls. The education-wise, a little around 6 to 17% of the children dropped after class 6 or 7, and majority of them continued up to 9 or 10, and then college-going students were around 32 to 40%. And household income you can see, and we collected BMI, MOAC, and waist circumferences. So if you look at the exposure to metals, here you can see that we have measured arsenic in urine samples of mothers. The first brown column is the mothers at early gestation of 8 weeks, and then children at 4.5 years, 9 years, and 15 years. And you can see that their urinary arsenic levels have gradually gone down. That means that their exposure has gone down, probably switching to less contaminated water. But if you look at the urinary cadmium, it was lower in children compared to mothers, but you can appreciate that cadmium accumulates in the body cannot metabolize it, so it gradually increases and gets stored in the body. So the cadmium was continuing getting higher. In 15 years, we have not measured it yet because it's an ongoing study. And we looked at various lipid profile and blood pressure and diabetes marker like fasting glucose and HbA1c. And here you can see that I have shown here 5 plots. The first one is cholesterol, then TG, then LDL and HDL, and at the right-hand side is the HbA1c. So you can see that children at 9 years of age already started having borderline increase in triglycerides and or high at 15 years, and LDL also started increasing, but HDL was low. At 15 years of age, it started going down. You know that HDL is the good lipid, and it has gone down dramatically in older children. So already there are perturbations and changes in the lipid profile. And if you look at the HbA1c, that was higher in 15-year-old children. Around 28% of the children had above the cutoff of this HbA1c, indicating that the early markers have started set in, and they are gradually increasing. Probably with exposure it will increase. So this is a regression plot. If you look at on the left-hand side, this is urinary arsenic, and this has been plotted against the different lipid markers, and you can see that in the HDL, which is the good lipid, it is lower against when they were exposed to in utero arsenic, and this remained low when they were exposed at 4.5 years of age and at 9 years of age. And interestingly, the other lipid like cholesterol was also low. So you can appreciate that growing children do need cholesterol for their growth and bone development. So whether good or bad, all the cholesterol levels were inversely associated with arsenic. With higher arsenic level, the lipid goes down. And with the cadmium, we see a similar picture, but more prominent. And these were also determined at in utero, then 4.5 and 9 years of age. And this is a plot where we have measured the plasma lipids in 15 years old children. And
ক্যামেরাম্যান মাঝখানে যিনি আছেন আপনি একটু সরে যান, আপনি কিন্তু প্রজেকশনে ইন্টারফিয়ার করছেন, একটু সরে যান প্লিজ, লাইটটা অফ করেন।
So, but interestingly, when we measured the lipid profile and glucose in 15 years old children, and we tried to associate with their current exposure marker, we didn't see anything. But the exposure at early age, like in utero, then 4.5 and 9 years of age, there the arsenic exposure had a dramatic effect. So it seems that early life exposure to these toxic metals have a strong effect on the biomarkers of cardiometabolic diseases. So this is the end of it. I have not shown data on air pollution or salinity because of time constraint, and I'd like to thank my collaborators in ICDDRB, in Karolinska Institute, in Uppsala University, University of California, and Tsukuba University. And this particular study at 15 years of age was funded by NIH and University of Tsukuba. So thank you so much.
Thank you, Dr. Ruwana Rakib. Thank you for finishing well ahead of time. But I think given that we are still running behind, so we'll park all the questions for the very end, and let's jump to the next presentation. Dr. Afreen Iqbal will be presenting demographic, socio-economic, and biological correlates of hypertension in adult population. This is from the the last demographic health survey of Bangladesh. So a bit about Dr. Afrin. She's a research investigator in the Maternal and Child Health Division at ICDRB, has been working there since 2014, and she has more than 6 years of experience in public health system strengthening and closely working with government stakeholders. She's currently leading a project to provide TA to non-NCD program of DGHS in automating the NCD management model. She has been involved in the development process of National Child Health Strategy of Bangladesh and has contributed to the life care of hypertensive and diabetic patients and NCD education manual for primary health care developed by NCDC DGHS. She's a physician, completed her master's in public health from JPG School of Public Health, Brack University in 2014. So with that, Afrin, please.
Thank you. Good morning, and with all due respect, I would like to present my paper which was published titled Demographic, Socio-Economic and Biological Correlates of Hypertension in an Adult Population. It is an evidence from Bangladesh Demographic and Health Survey 2017 and 18. To keep the background short, Bangladesh is well advanced in the epidemiologic transition from communicable to non-communicable diseases. I think those of us who have been working in public health for a while already know this. The major non-communicable diseases consists of hypertension, diabetes, chronic obstructive pulmonary disease, and cancers. And all of this, with their complications, account for 2 out of 3 deaths annually in Bangladesh. Hypertension, or elevated blood pressure, is one of the major non-communicable diseases and is one of the leading health risks globally. 2 rounds of Bangladesh Demographic and Health Survey back in 2011 and in 2017 and 18 show a significant rise in hypertension prevalence. It shows that among males aged over 35 are increased from 19.4% to 24%, and among females can you please mute your mic?
So, whoever is the host, please, can you mute other people, please?
And among females, 35 years and older, the prevalence of hypertension raised in 6 years from 32% to almost 45%. The rising prevalence of hypertension in Bangladesh did not necessarily increase the awareness or care-seeking patterns or treatment or in compliance. The Bangladesh Demographic and Health Survey in 2011 found that more than half of the adult populations who are of age 35 or older were not aware of their hypertensive status, and 2/3 of those who were aware were taking medication but did not have their condition under control. Another nationally representative survey, the STEPS 2018, also reported that half of the hypertensive were unaware that they were hypertensive or had elevated blood pressure, and only 14% had their conditions under control. All these facts and figures tells us that we need to dig a deeper dive into the latest Bangladesh Demographic and Health Survey, and that's exactly what we did. This paper used data from the latest Bangladesh Demographic and Health Survey to examine the latest nationally representative estimates of hypertension prevalence, awareness, and management among the adult population. The adult population of 18 years or above were considered. A total sample size was 12,769. Among them, 7,248 were women and 5,500 were men. 3 measurements of blood pressures were taken in a subsample of the BDHS population, and these blood pressure measurements were taken by trained technicians in seated position by a calibrated and standardized machine. Approximately 10 minutes interval were put in between each measurement, and the average of last 2 measurements were used to report the respondent's blood pressure. Before we go deeper into this study, I will introduce you to the outcome variables of this study. Hypertensive was defined following the 2003 American Heart Association guidelines. Respondents were defined as hypertensive if their systolic blood pressure were 140 millimeter of mercury or higher and their diastolic blood pressure was 90 millimeter of mercury or higher at the day of the survey, or if they were currently taking any medication to lower their blood pressure. The respondents aware was defined as if the respondents who had elevated blood pressure were told that he or she has hypertension by a healthcare provider. Treated means that hypertensive respondent who reported that they were currently taking antihypertensive medication on the day of the survey, and controlled meant that the hypertensive respondents who were taking the medication had their blood pressure under the above said threshold. So, to identify the association of hypertension awareness, treatment, and control with potential predictors, we followed an adaptation of the conceptual framework proposed by Wong and colleagues. It was developed in 2005, and we adopted it to fit this paper. The factors were non-modifiable factors, those which you cannot modify, like your age and sex. The contextual factors included the socio-economic factors, wealth status, educational level, and locality. The behavioral factors included diet, smoking, alcohol consumption, physical activity. The biological factor included overweight, obesity, and elevated blood glucose level, which all led to the health condition in this case, which is hypertension. Here, one disclaimer is that behavioral factors were not included in this paper because Bangladesh Demographic and Health Survey does not collect the data on diet, smoking, alcohol consumption, and physical activity. So we did univariate analysis and bivariate analysis between the outcome variables, and individual covariates were carried out. Then chi-square tests were done to see the proportional differences between them. To examine the demographic, socioeconomic, and biological factors affecting hypertension, awareness, treatment, and control, we used multivariate logistic regression models, and both crude and adjusted odds ratios were calculated for each covariate at 95% level of confidence. A staggering 27.5% of adults above the age of 18 years or more were hypertensive. When we compare with the 2011 data, the comparable age range is 35 or more. The 2011 did not have 18 or more years data. So here we can see that 26% of hypertensive population in 2011 increased in 6 years to 39% in 2017 and 18. Only 2 in 5 were aware of their hypertensive state, and only 1 in 3 of those were aware had their hypertension under control. In terms of percentage, 58% were not aware and did not take any medications. 5 were aware, were treated, but did not have their condition under control. 25% were aware and were taking medication, and at last 13% were not aware and were not taking any medication and did not have their condition under control. The correlates of hypertension were as such: the likelihood of being hypertensive, being aware, getting treatment, and having the condition under control increased gradually with age, and it was significant. Compared to men, women have 32% higher odds of being hypertensive. Women also had higher odds of being aware that they were hypertensive, and they were also more likely to take medication and controlling blood pressure levels. Apart from age and sex, the strongest differential was found to be the nutritional status, where being overweight or obese carries more than 4 times the risk of hypertension than being underweight. And when segregated by age, it was seen that women had higher BMI than men. So in conclusion, as an adult woman living in Bangladesh, it concerns me gravely that more women are being hypertensive than men. So it calls for a targeted approach catering to the high-risk groups and it should be thoroughly implemented. There could be ensuring quality antenatal care. We know that the coverage of antenatal care increased in Bangladesh, but ensuring the quality with additional component on awareness and prevention on major non-communicable diseases could be beneficial. We could also benefit from lowering the screening threshold for women in National NCD management model. Currently, we know that the National NCD management model caters to men and women 40 years or above. While screening is concerned, the adult population of Bangladesh is ever expanding, and we may benefit from including other private sectors and NGOs in the screening and awareness raising mechanisms. The public health by itself may not be able to handle the hypertensive population pressure. We need to act now and in close collaboration with other ministries and relevant sectors to bring an enabling environment for citizens to adopt healthy lifestyle choices, all of which are mentioned in the Multi-Sectoral Action Plan, which was developed for 2018 and 2025. The Multi-Sectoral Action Plan, developed by NCDC program of DG Health, repeatedly talks about bringing dietary changes, increasing opportunities of physical activities, mass awareness campaigns, focusing on treatment compliance, and curbing tobacco consumption. But we all know that only health ministry cannot do it alone. We need adequate fiscal policies, we need purchasing awareness regarding the purchasing choices, we need road transport authorities, we need mayors of city corporations involved so that all of these healthy lifestyle choices can be made. And at last, to end, currently we have 30 million adult population in Bangladesh who are hypertensive, and this number will increase to 50 million in 2050. So the time to act is now. And I would like to thank USAID RDM for funding the activities related to the secondary analysis of this paper. And we also would like to thank the co-donors of icddrb. Thank you.
Thank you, Afrin. That was very good. We'll jump to the next presentation, the final presentation, which will be online. Mr. Anwar Hussain, who's the founder and CTO of DocTime Limited. Has a master's in information system development from London Metropolitan University, 16 years of experience in various startups in the UK and European Union as tech strategist, has a vast experience in financial tech and health tech in the UK and Bangladesh. He technically architected, designed, and successfully delivered the first UK's fully digital FCA-regulated car retailer and financial broker platform. So, Mr. Anwar Hussain, are you online?
Yes, I am.
Thank you. So over to you.
Thank you. Can I share my screen?
Yes, please. Please proceed.
Whoever the host is, can you let me share my screen, please?
I think everybody has access. No?
Someone else is sharing, so they need to stop sharing before I can do.
Nobody's.
There is a Windows screen shared.
Just let me check.
Dr. Afrin's screen is shared in the screen.
No, that's been shared. Okay, thanks.
Okay, thank you. Right, I'm very excited and very honored to be here. Thank you, icddrb and Dr. Alia, for giving us the opportunity to participate in such a program and become the gold sponsor of this program. So we are a telehealth organization, and our objective here is to show how digital platform and digital healthcare can help NCD care easy and quicker. So if I take you through quickly the presentation. So DocTime is an online medical service platform where people get 24 hours on-demand consultation, electronic prescription, medicine delivery, home pathology test. We're also building electronic patient records at the back of our activity. In 2021, we have been able to reach about 1.5 million patients across the country. We now have about 850 approved GPN specialists on the platform, and our Play Store ratings are 4.8. So that's pretty much a very high level of doc time. So I'd like to give a quick background on how globally telemedicine and telehealth service has been used for NCD care. So as you can see that the telemedicine and telehealth care has been used globally in the developed and emerging markets to help doing a better care on the NCD patients. So if you see few points here highlighted, it helps better patient engagement and consolidated information. It focuses on preventive care and improve continuity of care and patient outcome. As you can also see, a couple of the articles published by World Health Organization, it says that digital health and telemedicine visits, electronic records, and prescriptions has successfully demonstrated the advantage of ensuring the monitoring and evaluating on interventions for NCD. About 75% of the medical provider feels that electronic patient records helps them enabling deliver better care for their NCD patients. So I would just like to do a quick 2 minutes video to show how telehealth and us as a DocTime services can help NCDs and how this works. We just give us one moment.
DocTime is a digital healthcare provider that uses advanced technology to improve the health and well-being of the population we serve. DocTime offers a number of services. We provide 24/7 on-demand consultations with GPs and specialists, online prescriptions, medicine delivery to your home, and integrated diagnostic tests. Our technology gives access to healthcare for all in a trustworthy and affordable way. It is particularly impactful for those who need it the most. You can get access to all the services through our homepage. DocTime is available as an app on both Android and iOS phones. We also have a desktop version, which is especially useful for doctors. Let's start with getting a video consultation. First, you choose your doctor. You can search for a doctor by their name or their clinical specialty. You can look at the doctor's profile. You can filter based on whether they're available today or if you want a female doctor only. From the filtered list, you then select your chosen doctor for a video consultation and make the payment online. Next, you enter the doctor's virtual waiting room. On average, our customers wait less than 10 minutes to start the consultation, and then the consultation starts. During the video consultation, you can send documents or photos to the doctor. These will be saved in your online medical record. At the end of the consultation, the doctor can write an electronic prescription. You can download the electronic prescription onto your smartphone. It's also saved in your electronic patient record. You can take the online prescription to any pharmacy to get your medicine. You can also order the medicine online through DocTime, and our partner will deliver it to you. You can also use the DocTime app to order a diagnostic test. As you can see, DocTime is absolutely committed to giving access to quality care and on solving the last mile with medicine and tests delivered to your home. But DocTime is also focused on your continuing health and well-being. We can support you at any time with the following services: medicine reminders, follow-up consultation reminders, save or download your prescription, add a family member to your account so that they can book and have a consultation, view your previous consultation history and your payment history. DocTime also provides you with health tips to help you to manage your health and well-being. DocTime is well connected to the best partners. You are in good hands with our healthcare service providers and our distribution partners. We also support medical research organizations with their clinical trials and research programs. We encourage you to download DocTime. Our team is very proud to give you access to the best possible digital healthcare services.
Thank you for watching. It was quite short. We are also at the back of our regular activities. We are building electronic health records, and which has been evidence. It's like an evidence-based healthcare, and we also doing various data capture, which helps us to do various research programs and supports public health goal. As you can see on the right side, as an example of our electronic patient records, where we are storing all their previous history, their current medications, their consultation history, their diagnostic reports, their allergy information, and also the lifestyle data, which is very useful for the NCD patients for preventive care or help them to get better health tips around. So this is a very, very quick sample of data extracted from our platform, where it's a mixing platform used by adult male, female, and children. Various age group has been covered, and in average, our patients wait approximately 10 minutes, less than 10 minutes to start a consultation. So as has been pointed out previously by Dr. Arun, that the importance of digital healthcare and telemedicine and electronic patient records for a better NCD care, the people get very quick access and with an affordable cost, where they can get a NCD doctor or a specialist within 10 minutes of start requesting for a consultation. So we've extracted some data around some NCD patients that we have on the platform. So like around 4,200 samples we have collected, where we have seen about 25% hypertension and 25% asthma across the 4,200, and around 7% represent the diabetics patient. An average age group of the diabetics and hypertension is 10 years more than our regular patients. These are quite important data we can collect just within from our database within minutes. The system has been designed so that's the advantage of using digital technology. The reports and data can be extracted relatively quickly. We are in the process of doing some digital activity around NCD programs and work very closely with icddrv. We plan to do it, and we are very proud to announce that we have allocated about $100,000 just for NCD program. Part of the money will go to the research program and building digital technology platform. We are already in the telehealth sector. We are already doing NCD patients looking after, and we would like to do more with the help of icddrv and other institutions around it. So this gives the digital technology gives people very quick and easy access to the doctors or healthcare system, especially in this pandemic, where people can, if we look at the NCD patients across the urban and in the rural area, it is very difficult to get access to doctors or hospital facilities for them. So our platform gives a quicker access and easy access to them, and we can help the various programs to closely monitor the patients, NCD patients, educate them with various things. We can do preventive healthcare, we can do various follow-ups, we can do using digital technology, automated text messages, personalized health tips to better improve the health and well-being of the NCD patients. So I'd like to thank everyone for giving us the opportunity to present this. Here are our contact details. Thank you.
Thank you, Mr. Anwar Hussain. That was excellent. So we are fairly close to the end of the session. I'll hand over to the chair. Any questions for any of the presentations? I'm hoping Dr. Arun Jose, you're still online. If there are any questions, and we have 3 physical presentations here, and Mr. Anwar Hussain is still here. So any questions from the audience or from the chat? I am unable to see anything in the chat. So if somebody can. So there's a question for Mr. Hussain. Is there an app of DocTime available in Google to download?
Yes, it is. It is available in both Play Store and App Store, and also the service can be taken from doctime.com.bd as a web-based platform.
So there is, and I'll have to read the questions. So let me from the very end. I think this is from me, Nabil Ashraf. My question to the panel is, informal healthcare providers constitute a major part of the roles. This is not specific to anybody, so let's do the specific ones. Somebody is saying there's already 500,000 people in Bangladesh have downloaded the app. Let me start from the, so Dr. Mubashir from Lesotho says, good presentation, Dr. Alia Nahid, please share your comment. Dr. Tasdeeq has said, my question to the panel is informal, so it's the same, it's a general question, maybe the chair can address that. Arun Jose to everybody, so I'm not sure, Dr. Arun, are you able to speak? Can you articulate your question? And are you addressing it to anybody?
Yes.
Okay.
Yeah. Hello. So there were two questions that were asked to me earlier, and I think that basically dealt with smartphone usage and the availability of smartphones. So I have responded to the two questions that were asked, and my opinion is the same. So I think smartphone usage has increased drastically over the last 1 decade. I think I just checked, and approximately 40 to 45% of people in Bangladesh actually use a smartphone already, and that number is set to rise to around 70% by 2025. So I think utilizing these smartphones are very, very important to improve access and affordability to healthcare. And regarding whether NGOs and other governmental agencies need to provide smartphones for their population, I've also suggested alternate form of healthcare delivery that we've been doing in India with the support of the World Health Organization, which is an assisted telemedicine healthcare delivery format. So in this format, what happens is a trained healthcare worker which has a smartphone and who has all this equipment available to them, they actually facilitate the telemedicine interactions for the patient and the doctor. So this removes a lot of the technology, the language-related barriers, and the literacy-related barriers. So the digital divide or the digital literacy gap is still very much prevalent in the world. And whenever we replace normal healthcare with digital healthcare, it's important to make sure that digital literacy and digital health awareness is advocated to the population so that they can utilize the alternate forms of healthcare.
Thank you.
So that's my response.
So thanks, Dr. Arun. I think that was I generally agree with that statement, and I think some of that is already happening. Moving through the chat box, Tanzirul Islam has made a statement that the health information through digital platform may be best effective to aware people nowadays, as the access for them to digital service is more easier. Dr. Mubashir from Lesotho has some comments. I don't know whether these are questions. I think his question was about whether an app is there in Google, and the answer was given, and that already there are 500,000 users there. So I think that there was a general question to the panel. Maybe I'll ask Dr. Zaman to deal with this. Farhan Akhtar, is there any large-scale data about popularity of telemedicine among urban and rural patients? I don't know if anybody can answer that question.
I'm not aware if there is any.
Okay. Is there a large-scale data about popularity of telemedicine among urban and rural patients? I don't think there is any data like this. Okay. And
I think I'll just quickly say a couple of words around. So the DocTime app has been used across the country in 64 districts, and we have about 500,000 patients has already people have already downloaded the app. So that's pretty much some data we have.
Thank you. I think that's useful to know. Zahir has a question probably to Dr. Nahid. Cobra BPS shows excellent results. Is there any plan to scale up the program with the existing health system?
Thank you for the question, very important one. And this exactly was my final comment. So the scale up is
extremely important. But now we have to think about remodeling, repurposing our resources. So we cannot go by the modeling of the previous human resource intensive activities by the health workers and the medical doctors. We need to integrate digital platform in a very smart way so that it reduces the cost and also use of human resource time. Thank you very much. And we are working with the NCD Control Program and DGHS to develop a platform for that, and thank you.
Thank you. So with that, I think we can close the Q&A session and hand over to Dr. Zaman for a summary and in his last final thoughts on this.
Thank you. Thank you very much. All the questions, in fact, came from the chat box. Is there any burning question from the floor? I don't see.
Nahid wants to ask.
Nahid, please.
You have the microphone. Oh, sorry. You did have the microphone.
My question is actually to, I think Dr. Rubana Rakib, and also I see a lot of endocrinologists here. So this is the dilemma we are seeing in NCDs, that malnutrition and macronutrient and micronutrient deficiency is very prevalent in this country, and we are seeing a lot of dyslipidemia in this country. So what would be the basic interrelationship of this scenario in Bangladesh, while 30% people are still suffering from undernutrition? Any comment, any explanation, and any way forward direction for us?
Thank you. Yeah, I'm not exactly sure, but undernutrition does play a role in all susceptibility to different types of infectious disease as well as NCDs because of the imbalanced nutrient people take with higher fat and lower protein. So it has to be a balanced food, probably with more protein and so on, so that it can protect them from different types of pathogens or toxic exposures and so on. And malnutrition is very prevalent, so this has to be stopped, especially among women and children. So that area needs to be addressed if you want to address the communicable diseases.
Thank you. Thank you very much. Thank you very much. Thank you, the presenters. Wonderful presentations. Lot of thought-provoking data and information. One of the points came to the center of discussion for everyone is digital technology, use of digital technology for controlling NCDs. If I give a background of NCDs in Bangladesh, NCD risk factors, we all know, but I would, for benefit of common understanding, I would like to list them. As a risk factor, we have hypertension, diabetes mellitus. Among the behaviorals, we have tobacco and dietary salt intake. These are very common, very common. And if we want to address some risk factors that needs also treatment, from that point of view, these are diseases also, not only risk factors. These are hypertension, diabetes mellitus, and cholesterol or lipid abnormality that one of the presentations covered. To address these at the community level, we can utilize the digital technology. And using these digital technology, Upazila health complexes could be well connected to the secondary care and the tertiary care as a backup for expert advices, because some of them at certain point might need advice from the experts. So we have the backbone of health infrastructure in rural area especially, and we have the people there, and they can well be connected using the smartphone that Dr. Jose tried to mention. However, we also need to mention that use of smartphone is not that common in this country, but we can confidently say that almost every household has a cell phone. So using that cell phone, we can access almost all the households, including the ultra poor. This might be a surprising information for those who live outside the Bangladesh, but these ultra poor also use this cell phone as their livelihood. Therefore, we can easily connect all the households using this digital technology. Dr. Alia Nahid gave a very important data that the control of high blood pressure is cost effective. So if that is the case, it has a high potential of scale up. And now the question is how we can do it. Unless the existing health infrastructure or health system is not engaged fully, then we cannot do it. And there is a pertinent question from Dr. Tasdiq Deep, if I remember correctly, that there are a lot of informal providers, and how do we connect? Yes, using this digital technology, we can connect them, but we also need to be aware about the misuse of the technology. Therefore, the technology per se is not the solution. The solution lies how we utilize the technology. The next presentation was from Dr. Rubana Rakib. She has given a very nice clue about cholesterol, lipid abnormality related to the toxic chemicals exposure in early lifehood. In Bangladesh, when we talk in the arena of cardiovascular disease, mostly we discuss triglycerides. We commonly say that because we eat a lot of rice, we have a problem of triglycerides. But that may not be the number one problem in terms of lipid abnormality. To my experience, low level of HDL is number one. And that's what she has also mentioned, not only in adults, even in childhood, this can be a big problem. Then Dr. Afrin emphasized the issue of screening of blood pressure. If I recall our experience, I see one of the former health secretaries is here, sir. In the past, we had geographical reconnaissance done by the health workers. They used to go to every household. They used to map a moja, list all the households and household members. And that work was paper-based. And they used to take information about the age and sex composition, then EPI coverage, and vitamin A capsule distribution, etc. Those were related to the programs government is executing. We had an intention that if we could tag blood pressure measurement, or if we could give a glucometer to them, then all the households could be covered under the screening system. And that's a very feasible option. Unfortunate thing happened in 2011, if I remember the year correctly. There was a circular from DGHS that from now onward, there will not be any paper-based GR. So the health workers stopped it. And DGHS tried to make it digital, and that never happened. So if we could undertake the journey again, sir, because our people are oriented. So be it digital, be it paper-based, if we can do it, we can cover almost all the households in the rural area for diabetes screening, hypertension screening. So that's the point I wanted to emphasize. And Mr. Anwar Hussain made the final presentation. So he gave us a clear information that using digital technology, people can get information, they can get the consultation, they can get the counseling. However, the technology should be tagged to the health system. And that's what we have in our rural area. However, sir, I would like to ask a question. What is happening in the urban area? We do not have any primary care infrastructure in the urban area, although more than 30% of the people in Bangladesh live in urban area. So there is a, whether I should use this term, hassle between the local government and the Ministry of Health, who is to take care of the primary care in urban area. Whoever takes care of the urban primary care, the need for taking urban primary care has come. It is already delayed, so we should be able to have something like health complexes, something like medical post in all the city corporations, all the Paurasabhas, so that the Bangladesh people can be brought under the screening system for prevention of hypertension and management of hypertension. With this, I would like to thank the organizer, Eminence, and the wonderful world-class scientist for making this presentation, and also my co-chair, who is a reputed scientist known globally, not only in Bangladesh. We believe ICDDRB, in collaboration with the organizer and the Ministry of Health, will be able to take the agenda of NCD control in Bangladesh. Thank you very much.
Thank you. So with that, this session is closed. The next session is, I understand, it will start immediately.